Um, I'd like to introduce a few people that we have on the call helping us today. And before I do that, the topics today are e-prescribing and PQRS. We're going to spend 40 minutes on e-prescribing. That includes a few minutes for Q&A. And then we're going to spend the last 20 minutes on PQRS. The experts that we have on the phone with us today are Lisa Ashton and Deanne McCallum, and they will be taking us through the presentation and be available for the Q&A portion. And then I'll be taking us through the introduction to PQRS. We had initially expected to do more work on PQRS, but when we looked at the content, it just was not able to fit, and we will have a more detailed, in-depth PQRS in some dates that will be at the end of this session we showed. So first I'd like to introduce Lisa Ashton, and Lisa, go ahead.
Hi, this is Lisa Ashton, and I'm very pleased to be here today. I am clinical faculty at UCSF School of Pharmacy, but I've been on assignment at the state for, well, since about 2008, working both with the Medi-Cal EHR incentive program, and I'm most currently under the direction of Pam Lane, who is in the Office of Health Information Integrity at the California Health and Human Services Office. So, next slide. So I'm going to talk about what we need to know about e-prescribing now. So before I begin to talk about how to avoid the adjustments for the EHR incentive program, I want to just take a quick moment to talk about what I believe is true e-prescribing. And there are some very long, complicated explanations out there, but really, to me, what true e-prescribing is computer-to-computer or end-to-end electronic prescribing, not a computer-to-fax prescribing. And for a pharmacy, that means receiving electronic prescriptions directly into the pharmacy software system. And for providers, it means that your renewal requests are sent electronically from the pharmacy and reaches your electronic system for e-prescribing. Next slide. So the initial focus on e-prescribing as sort of the foundation for health information technology and exchange is really for its potential for improving care and lowering costs. And at the top of this list is around patient safety and its ability for e-prescribing to reduce medication errors, and primarily through the elimination of illegible handwriting by providers. It provides access to more complete and accurate medication histories. It decreases costs and increases formulary compliance. There's a decreased risk for adverse drug events through drug-drug and drug allergy interaction alerts. And it increases the access to clinical decision support, including drug safety alerts, adherence reminders, and alerts for gaps in care. It also can reduce the time spent on the prescription process, therefore increasing efficiencies, especially by reducing the number of callbacks and renewal requests from pharmacies. And from a patient standpoint, it can improve convenience for the patients, as the prescriptions are going to be at the pharmacies when they get there, and therefore can improve patient adherence. Next slide. So underneath what appears to be a straightforward concept of computer-to-computer exchange is a really complex process that requires some significant technical assistance, as the products aren't normally just ready to use off the shelf. And so providers have been reluctant to put in the effort to implement electronic prescribing, because there hasn't really been a clear indication there is a return on investment. There's other barriers that have been faced by people who have, the providers who have adopted electronic prescribing, and that's an inability to identify pharmacies in communities that may be capable of electronic prescribing. And more recently, the DEA regulations around the electronic prescription of controlled substances, or EPCS, are confusing. And although the adoption of this technology has been slow, we do know that there will be challenges, and we'll have to work on workflow when that becomes more widespread. And also, one of the major barriers in California for e-prescribing are in rural areas where prescribers may face some connectivity and broadband challenges. Next slide. So the implementation steps are, there's 4 steps here, but again, each one of these steps could probably be an entire webinar. But basically, it's straightforward. The first thing you do is you have to see what is needed, or determine what your needs are for e-prescribing. Training. There needs to be a training process that's developed that accounts for not just initial training, but ongoing training needs as well. And then advanced coordination with other providers, with patients and pharmacies in the area it's very important as the workflows are changing. It's a lot. It's a much more closed system now that you have to communicate electronically, and it's really important to look at more of the mega workflow process now instead of just looking at the workflow within your offices. And then preventing and preparing to handle common problems. Although this is pictured here as a last step, I think it's almost something that has to go on during the other steps as well, because understanding and preventing common problems is really a critical piece that shapes both what your training program looks like and also advanced coordination of activities. So one of the e-prescribing systems that's available to you in Santa Cruz is the Elysium product. And I'm going to let Bill talk a little bit about this.
Sure. Thanks, Lisa. So everyone that is a authorized e-prescriber or authorized prescriber in Santa Cruz is able to use the Santa Cruz Health Information Exchange solution that's part of what's called EMR Lite. There is no fee for that to you. And it is open to any user in Santa Cruz, not just PMG users. It is fully integrated with the exchange and with the Community Patient Index. So most of the patients are already in the system. That means you don't have to have entry of patients. Sometimes you have to update demographics, but you don't have to enter the full demographics for the patient because most of them are in there. And you don't have to worry about trying to build an interface to some other system like your practice management system. So that is available. It is free at least through December 31 of this year, and we hope to be able to make it free in 2014. We're just looking for our funding sources there. One other thing that we're looking to bring into the picture in 2014, assuming there's demand for it, is the ability to do e-prescribing of controlled substances. So I know this has been a challenge because if you do a lot of controlled substances, they cannot be done through the e-prescribing system that's there today, and even in most of your EMRs are not able to do it yet either. So we're looking to see if there's a reason and a demand to do that. That will be a more costly solution as well, and we're seeking funding for that, again, assuming there's demand for people wanting to do e-prescribing that's not part of your EMR, if you have one. So if you are going to want to take advantage of this, and you're going to hear from Lisa some more about deadlines and things that you need to do now, you need to contact Dawn Mackey and enroll with us by June 7th, because it can take up to 10 days to get you completely enrolled in the system, and you'll hear more about what you need to do before June 30th in order to avoid the penalty. Lisa, back to you.
Great, thank you. So I think for most of the rest of this program, we're going to concentrate on what needs to be done for the CMS e-prescribing incentive program. And just to review a little bit of where this came from, the Medicare eRx incentive program was established by the Medicare Improvements for Patients and Providers Act, that are known as MIPA, of 2008. And it uses a combination of incentive payments and payment adjustments to encourage electronic prescribing by eligible professionals. In this program, 2012 was the first year that the program applied a payment adjustment to eligible professionals who were not successful electronic prescribers on their Medicare Part B services. The 2013 eRx incentive program reporting periods. There are two reporting periods, and this is really important to keep straight because the programs become very confusing when you combine them with the other CMS programs that have come out under separate legislation since this original e-prescribing program came out in 2008. I think what we're going to do is just really concentrate on what you have to do for the eRx incentive program, because that's the one that where the penalties are going to hit hardest in the near future. So in this eRx incentive program, there are two reporting periods. The 12-month period for 2013, which is January 1st to December 31st, that only applies to the 2013 EHR incentive payment. And this is the last reporting period that you can earn an incentive of 0.5%. The reporting method for this is they have three ways that you can report for the incentive program. It's by claims, by registry, or through an electronic health record. The claims for the incentive part of this program is they must be processed in the National Claims History File by February 28th of 2014. The second reporting period that's associated with the eRx incentive program is January 1st through June 30th. And that only applies to the 2014 eRx payment adjustments. So this time period is the last reporting period that you can become a successful e-prescriber in order to avoid the 2% payment adjustments that will hit in 2014. And for this reporting period, you can only report using claims. So the claims must be processed into the National Claims History File by July 26, 2013. So just in looking at this is a very complicated slide, but the main point here is that to note that in the eRx program, that not all of the eligible professionals that are eligible for incentives are subject to payment adjustments. So the optometrists, the oral surgery, dental medicine, chiropractic are not subject to the payment adjustment. However, that's not true when you look at the EHR incentive program, which is the program that follows the CMS e-prescribing program. So just be aware that in the EHR incentive program, even though these disciplines are not subject to payment in the eRx program, they are subject to payment adjustments through the EHR incentive program. Next slide. So for the 2013 EHR incentive program, to qualify as an eligible professional, again, we're looking at the reporting period between January 1st and December 31st of 2013. An eligible professional needs to report the e-prescribing code of G8553 at least 25 times in the unique denominator eligible eRx events. And we'll talk a little bit about what those are in a little while. This is just the requirements for reporting as a group practice organization, and I'm just going to skip through that because I don't think there are any on this call. So some helpful tips for the eRx incentive program. First, determine if you're eligible to participate at the link that's provided on the slide. You need to review the 2013 eRx measure specifications in the eRx section of the website. I think you can find that where it says educational resources. And then determine if your practice has the resources that are needed to participate. And the first thing on this is the qualified eRx system or a certified electronic health record. And then you need to determine if your Part B eligible codes in the denominator of the measure make up at least 10% of your physician fee schedule allowed charges for the year, and then follow the required steps for reporting. To look at the eRx measure, there's a numerator and the denominator. Of course, the numerator is the G code for electronic prescribing, and then there's a number of codes that are qualified for the denominator, which are listed here, and you can also find that on the CMS website. Next. This is a real busy slide, and this is from CMS, but the main point on this is that when you're looking at the CMS 1500 claim, and you have on line 1, you have the 99202, which is the one of the codes that's eligible for the program, and when you have one of those codes, or you're one of the visits that applies to that code, you add on the second line the G8553, which indicates that there was an electronic prescription that was produced during that visit. You also see that that has a charge of 0.00, and in some of the claims processing systems that will reject because you read a number there. So in that box, if it rejects, or just, I would just go ahead and put a nominal amount of 0.01 or 1 cent in that box to make sure that the claims go through. That amount won't get paid, but it will keep the claim from rejecting by having at least 0.01 in that box. And for the requirements of 25 claims for the incentive program or 10 claims to avoid penalty, it's probably a good idea to submit more than those amounts. So submit more than 10 claims just in case some of the claims reject. Next slide. So more on tips for the incentive program. The new prescriptions that are not associated with the code in the denominator of the measure are not eligible visits, and you can't count them. Electronic generated renewals not associated with a visit do not count, so the ones that come in outside of patient visit don't count. Multiple prescriptions that are electronically prescribed at one visit only count as one eRx event, and that faxes don't qualify as electronic prescribing. So the next section is how to avoid the 2014 adjustment. So the important date is that June 30th date that's coming up in just about a month. So just so it's clear on what needs to be done, you need to enroll for the free eRx tool by June 7th if you're going to be trying to implement a new system by the end of the period. And again, you need to complete 10 eRxs by June 30th to avoid the adjustments, and submit 25 by the end of the year in order to qualify for an incentive. Next slide. So those providers, or if you don't want to be subjected to an adjustment, you can avoid the adjustment if you are a successful electronic prescriber. That can be accomplished by either reporting the eRx measure for 25 or more unique eRx events for eligible encounters that were part of the January 1st to December 31st, 2012 incentive reporting period, or to report an eRx measure via claims for at least 10 unique eRx events for the eligible counters between January 1st and June 30th of 2013. Again, it's coming right up, and that those claims need to be processed by July 26th. You can also avoid the adjustment if you're not a physician, a nurse practitioner, or a physician assistant. You can avoid adjustment for hardships, but it looks like that none of this is applicable to the Santa Cruz providers. So if you're not in a rural area, there are sufficient pharmacies, and most on this call have prescribing privileges. You can avoid adjustments if you file fewer than 100 claims containing the encounter code in the EHR measure denominator in the first 6 months of this year, or if you have less than 10% of your Medicare Part B fee-for-service or physician fee service total allowed charges are comprised of those codes that are indicated in the denominator. Or you can report a significant hardship code, and CMS will determine if the hardship applies on a case-to-case basis. So the best way to avoid the adjustments is really to become a successful e-prescriber under the eRx incentive program. If you, the first way is to have already been demonstrated that you are a successful prescriber in 2012, and then again for the first 6 months of this year, you need to report at least 10 Medicare Part B physician fee service encounters. And this slide comes from CMS, and this is something that I guess I didn't completely understand until I saw this. But to avoid the adjustment, your claims do not have to be coded with one of the eRx measured denominators. It just can be any of the Medicare Part B claims that, or 10, that have the G853 in the numerator. And that's only for avoiding adjustments. For qualification for the incentive, it does have to be, the code needs to be one of the measures denominators. Next slide. And then this is again for G-Pro. We'll go right through that again. And this is just to illustrate it has to be done by claims. So the hardship exemptions that can be filed that are due by June 30th as well are if you're in a rural area, which we determine Santa Cruz is not. There are limited pharmacies, which Santa Cruz does not have. If you're unable to e-prescribe due to local, state, and federal laws, and that's not true in California, or you have limited prescribing activity. So, for example, you generate fewer than 100 prescriptions during the 6-month reporting period. In addition, you can become a meaningful user of electronic health records during 2014, the 12 months of 2014, and also during the payment adjustment period that ends on June 30th, to not be hit with an adjustment, or you can demonstrate your intent to participate in the EHR incentive program and adopt a certified EHR technology by going to the registration and attestation page for the EHR incentive program and putting in the certified ID for your electronic health record system. This will be an automatic exemption that's done by CMS by looking at their registration and attestation page. So these are the eRx Incentive Program 2013 milestone dates. And again, the June 30th, 2013 is the end of the 6-month reporting period to avoid the 2014 eRx payment adjustment, and it is the last day to apply for a hardship exemption through the program. In the fall, providers are scheduled to receive their 2012 incentive payments. The CMS is going to be providing eRx feedback reports to providers to let them know what the impact, or to show them whether or not what their adjustments would be in the upcoming year. And at the end of December, the participation year ends for the eRx incentive program. So this is an example, even though the two CMS programs for eRx and EHR are separate programs. They're voluntary, but the penalties are you're subject to both, even though they're separate programs, that you could get penalized by both programs. So this is just an example of if a provider is not a meaningful user in 2004, and these adjustments are shown as they assume that less than 75% of eligible professionals are meaningful users for the calendar year 2018 and subsequent years. So in the first and the top row, in the top graph, is if an eligible professional is not subject to payment adjustments for the eRx program, that means they're a successful electronic e-prescriber, but they did not qualify for the EHR incentive program. In 2015, that will be the payment will be a 1% less. So it's 99% of the billing for Part B. The bottom row shows is an EP who is neither a successful e-prescriber and has not become a meaningful user. And that's where you see that 2% in 2015. So that's 98% will be what your payment is. And then the other, going down, it's the same for both, whether or not if you didn't achieve success in either program. So the place where this hits is in 2015 if you're neither a meaningful user or you're not using the e-prescribing in 2014. So the second graph just shows a different scenario where that more than 75% of eligible professionals in the nation has achieved meaningful use by 2018, and it's a much smaller penalty. So this is a decision tree that was produced by CMS, and I think it's really useful because this is a lot of complicated information. And so they use these on their recent calls, and I found them to be very useful. So this is the decision tree for the 2013 eRx program. So the first question you ask yourselves is, did you report the eRx measures numerator code at least 25 times in 2012? If yes, then you avoid the 2014 eRx payment adjustment. But if you didn't, that's the next slide. So if you didn't qualify for the incentive program in 2012, then do you expect to report eRx measures numerator code at least 10 times by June 30th? If you do, then you avoid the 2014 eRx payment adjustment. And then the rest of that tree is just to say that you can't qualify both under the EHR program and get paid under the eRx in the same year. So, but if you don't qualify by June 30th, then do you qualify for a hardship exemption for 2014? And if the answer to that is no, then you are going to be subject to the 2% eRx payment adjustment in 2014. So if you think you have an exemption, you have to, again, apply for that by that magical date of June 30th, 2013. So I think these are really helpful to walk through that program. So another important item is that does CMS have your current information? And this is really for the purposes of receiving that physician feedback report about whether or not you're going to be receiving an adjustment. So in order for them to have to contact you or to send you your feedback report, you need to go into the PICO system, and there's a website there to make sure that your information is up to date. Next slide. And so the take-home from this presentation, which was very abbreviated relative to the amount of material that's out there on this program, is that the eRx and the EHR incentive programs are separate programs. You have to keep in mind that each has separate criteria for receiving incentives and also avoiding payment adjustments. And you really have to pay attention to both of those time frames. And that really the time is now to avoid payment adjustments and to maximize your incentive payments through this program. And the contact information, again, for Dawn was on that side. And then the CMS resources, that there's just a wealth of information on these websites from CMS. There's a new eHealth webpage, specific information to the eRx incentive program. There's frequently asked questions. They're a little tedious to go through, but you have to just come up with the right search terms. And then there's John Langmead, who's just really been helpful to me when I'm trying to get questions answered or I don't understand something, and he's available. He's there's his email there, and his phone number, and he really is open to having people call him when you have questions about his program at times. So I think that is next slide.
Lisa, excellent job. And we have about 5 minutes left for questions for both of you. I want to remind everybody that all of these slides are going to be posted on both the PMG portal, for those of you that are PMG members with a login, as well as on our public site at the Santa Cruz HIE site. And we'll be posting both the recording and the slides. And like Lisa said, you might want to look at that decision tree and maybe print that out to refer back to it in the coming months. I'm going to attempt to unmute everybody. And if you have a question, if you could make sure that we can hear you before you ask it, so that we don't have people that are talking and we're not able to hear you. So I have to do this one at a time. And if you're in a loud area, if you'd mind, go on mute if you're in a loud place. So right now, everybody's unmuted. Are there any questions for Lisa or DM? Okay, I'm not hearing any questions. I don't know if anyone is asking questions.
Nobody has to give you the thumbs. Bill, one of the questions.
Go ahead.
Yeah, this is Randy, Santa Cruz Orthopedic.
Yes.
Since we're on our second phase, we did the first one last year. Is it just Medicare patients or all patients for these prescribed?
Lisa, do you want to take that?
I'm sorry, I wasn't trying to understand the question. So the e-prescriptions are for all Medicare patients? Is that what the question is?
Well, we did that last year, and then we're in the second year, so do we have to do it for all patients?
You know, it's for the incentive program. They're only looking at Medicare claims, and so I would imagine if you have a system that you should be using it for all patients, but I don't believe that it's not a requirement for Medicare that you do it in all patients.
Okay. We're doing it. Yeah,
Yeah.
we're doing it for all, but
Meaningful use is for all patients,
Yeah.
not just Medicare patients. And that's a great question, and I guess we're not sure if you're asking specific to the eRx or to the meaningful use EHR incentive.
well, kind of both.
Whoops.
But Lisa, I believe you're correct for the eRx that it is looking at Medicare claims. So therefore, it would not know if you had a larger population that were not billed to Medicare. It's looking for that 10 or 25. And then for the EHR incentive program, it's all patients, not limited only to Medicare patients.
Is that for first year too?
For the EHR incentive program?
Yeah.
Yes.
This is Bill. If I could ask you all to look at your control panel here on the GoToMeeting and make sure that under audio you have just the telephone checked. If you have microphone and speakers and you're talking on a telephone, it will cause a fair amount of feedback that we're hearing right now. Thank you.
They have two.
Are they in?
Nope, they're not in yet.
So, Randy, if you have any follow-up to that, give Dawn or myself a call.
Okay.
Is there anyone else that has a question for our experts on the call? Okay, well, I'm going to mute everyone again, and then we're going to do the introduction to PQRS. Okay, so again, we were hoping to do the full PQRS and e-prescribing in the same session, and it just didn't fit. So we decided to do PQRS as an intro for 20 minutes, and then we have a follow-up 1 hour on PQRS later in June. So first of all, this program is the program that was formerly known as PQRI, and when it was known as that, it was truly an incentive, meaning if you did it and you qualified, you got money. Additional money based on your CMS claims. It's moved from a incentive program that was optional to a program that if you don't participate, it will be a penalty. So it provides you with this payment if you report the data, and just like all the other programs out there, there's certain things that you need to do. And there's action that you need to take in 2013 that we're going to get into today to avoid a penalty next year. So, I'm sorry, in 2015. So it kind of sneak up on you. If you don't do anything and you forget about it this year, you are guaranteed a penalty in 2015. So it's once you understand it, it's relatively easy to do. It's like everything. There's going to be some workflow changes, but it will pay off in a number of ways. So you can, to avoid this penalty in 2015, you can start doing PQRS now. And we have put some links in through the document here that you can do some reading on by yourself as homework. But I'm going to try to hit the highlights that you need to know as an introduction. So first off, the PQRS guidelines and documents and measurements could change year to year. So even if you participated last year or prior years, don't assume that the same codes and the same parameters apply. So you need to pay attention to that on a year-by-year basis. You need to determine if you're eligible to participate. And most of you, if you're submitting to Medicare, you are eligible to participate, most of you. And you're also subject to a penalty if you don't participate. You have two options. Depending on the kind of practice you have, you would pick things that are appropriate. So in a slide, in a few slides here, I show an example of a neurologist. So the measures that a urologist would pick are different from the measures that perhaps an internal medicine doctor or a family doctor might pick. So there's some flexibility, and that's where part of your education needs to come in, as to determine what measures you want to submit. And you can either select 3 measures to submit, or you can select 1 measure group. And there's 3 different ways to submit. And you can either submit through your EHR, which I said is not common. We took a look at the EMRs that were supporting this capability, and very few of them are relative. So reporting that way through the EHR, just because you're capturing the data in there, does not mean it's going to get automatically reported. Likewise, with a registry, there are registries that you can submit your data to that will send it to CMS, and that's a possibility for some of you, but both the EMR reporting and the registry are not very common. So most of you will be reporting by claims. And what you need to do is, if you select that method, is that 50% on 3 or more individual measures for the 12-month reporting period need to be claimed, or 1 or more measure groups for the 12-month reporting period for 20 or more unique patients. So it is not a high bar to clear. However, the hope is from CMS that you'll apply these measures to all of your patients that you see, because they're based on national standards, and believe that by capturing, tracking this data, that it will improve the patient's health status. Here's that example that I told you about neurology. And I just showed 2 of the possible measures. They have, or 2 of the possible measure groups, and they have a number of different measures for each type of specialty. So in the first example, you can see the stroke as a disease status that you're going to track, and the reporting mechanism, which can be either by claims or by a registry. Again, we think the claims method is the way that people will report. It's much like the e-prescribing, where you're going to be putting a code and potentially some additional modifiers, but it's the straightforward and most easiest way to do it. The second, sleep apnea, if the doctor chooses to do sleep apnea, you can see that's only through a registry. So you need to pay attention when you pick a measure, that if you like the measure, make sure it's something that you can report, that you have a vehicle to do that. So what that means is, if this doctor picked sleep apnea as his focus area to report on, he would have to find, or she would have to find, a registry that will take their data and will submit it. I think that most of the registries charge a small fee for that. So there again, something to consider. The claims is virtually free between you and your biller as you submit things, but the registry may charge you a fee. The same is true for EMRs. If you're lucky enough to have an EMR that has been through the certification program for this, they may be able to do it through the EMR, but they may charge you a fee. So this program still has some small incentives left. so that if you report this year, by the end of the year, for a minimal number of patients, you can get a 0.5% incentive. And the same thing for next year. However, if you don't report in 2013, you will get a 1.5% reduction in 2015 on all of your Medicare payments, and you will get a 2% reduction in 2016 on all of your Medicare payments. So it's pretty substantial. You can read this, who can participate, and there's also a link here to help you determine who can participate. It's basically all of the Medicare doctors that are submitting to Medicare. We've got a few links for resources here. Again, feel free to follow them as homework. This is only meant to be an introduction and not the whole story. And we wanted to share a couple of more resources with you that we're planning here. And as the Santa Cruz Health Information Exchange, open to all the stakeholders in Santa Cruz, these are the webinars scheduled for the next month and a half or so. We have the full PQRS on 6/13, where we will have an expert speaker spending an hour with us, with you on that. In July, middle of July, we're going to have the introduction essentially to Stage 2 of Meaningful Use, which begins to go into effect January 1 of 2014, but for many of you it won't be going into effect until October of 2014. So we'll be enlightening you as to what changes are in store for Stage 2, as well as what you need to do to prepare for it. And then on the 18th, we'll be speaking about direct messaging. Direct messaging is essentially secure mail. It's required in the EMR vendor support for Stage 2, and so it's a topic that deserves its own hour or half hour of time, depending on how it lays out. And we think that you'll be pleased with the options that direct messaging can give you for secure communication. So contact us at our help desk number shown there, and you can ask for Dawn or Becky or myself, and we'll either talk with you directly or get you engaged with the right resource. And I had a slide here that's missing. We have a few minutes. Let me find it. Becky, do you know where that slide got to? The matrix? Okay, well, I'm going to just speak to it. So PMG and Santa Cruz Health Information Exchange put together a matrix of services to help you with PQRS. I'm going to send it out to all of you so you have it, because it defines the level of services and the number of hours of support that we're offering for free and services that we're offering for free to help you with PQRS. And it addresses people that are in the PMG billing service, as well as not in the billing service, and those that are hosted by us and not hosted by us, and those that are using other EMRs. So apologize that we missed that slide somehow in our final build, but I'm going to now once again try to open this up for questions, and while I'm doing that, give me just a moment, because I have to do each one individually. Okay, so everyone's unmuted. Is there any questions that people have about PQRS or the PMG services through PHIE? believe everyone's unmuted. Is anyone trying to ask a question? Okay, well, let's end early, give you a few minutes of your day back. Again, we will be making both the recording of this available as well as the slides themselves on the PMG portal and on the Santa Cruz HIE website. And I will send out that matrix of service offerings.